Hello, it is noon and we are going to be, this is the redo of our webinar that we did last week on hyperpigmentation and how to treat it effectively. We had some technical difficulties last week. It was really hard to hear, so we just decided to redo it. So Dr. Beckman, of course, was gracious enough to join us again. For those of you who aren't familiar with him, he is the CEO of Theraderm. He is a board-certified plastic and reconstructive surgeon, as well as he was recently appointed to the Department of Dermatology at UAMS as a clinical associate professor. So that's super exciting to have him on board and to be able to talk to us about all things skin. So also on this webinar, we have Darla Smith, who is our general manager. She also manages a wholesale territory as well as our esthetician accounts, and she handles the UK. So Darla has a lot on her plate, but she also knows a lot about skin and how Theraderm works with the skin and how to help you guys get the most out of your practice. So here we go. Let's get started. And I believe Darla is going to start sharing her slideshow.
Hey guys, I guess everybody, because I'm kind of new with this, everybody can see the slides. We are talking about hyperpigmentation, and Dr. Beckman will jump in and help me out through these slides. So basically, what is hyperpigmentation? It occurs when the skin produces more melanin in some areas than other. The irregular placement of overproduced pigmentation is what causes spots or patches of skin to appear darker than surrounding areas. And I'm sure when you're working on patients that you've noticed they've got some brown spots. They tend to be kind of up in the eye area, down on, kind of lower on the chin area. And that's what we are looking at as hyperpigmentation. They can affect any skin type. Most common areas affected include skin with the most UV exposure. So face, if you look at a person's face, like from driving in the car, that their left side of their face is going to show more damage from the sun because the sun is coming in the window. Your arms, your hands, where you get a lot of dark spots. And of course, a lot of people get it on their legs from being out in the sun, the lower part of their legs getting damaged. Other causes of hyperpigmentation, of course, the sun, UV overexposure, skin inflammation or injury, melasma, reactions to medications, medical conditions. Dr. B, do you have anything that you can add on, especially skin inflammation or injury or things like that?
Well, I do. Let's back up just a little bit on your previous slide about causes or what is hyperpigmentation. Melanin is the brown pigment in skin, and the amount of melanin that is produced by melanocytes, the special cells that make melanin, is what governs the darkness of color in the pigment we see, the coloration that we see in skin. And normally those melanocytes are in the epidermis at the basal layer. And about 1 cell out of every 20 cells in the basal cell layer would be melanin producing melanocytes. Those melanocytes, the number of melanocytes really doesn't change, but something can cause one or more of those melanocyte cells to produce more. It'd be like 4 or 5 different factories, and one factory producing 10 times as many chairs as another. So there'd be more chairs in their shipping department than the other factories had. So hyperpigmentation is an excess of that melanin, and sometimes it's caused by all of the cells producing more melanin. More commonly in the situation where we might see a dark spot, that's a certain group of cells are producing more melanin than the rest or the remainder of the cells. But any skin type can be affected by an overproduction, regular or irregular production or distribution of pigment. And as our slide shows there, any area can be involved with that. Most commonly, the sun-exposed areas of our face or arms are the areas that also are noticed by other people and cause not necessarily painful or otherwise difficult problems for patients, but as we all like for ourselves to look, quote, beautiful or normal or whatever, undamaged skin, I guess. So that causes people to seek advice and treatment from estheticians or dermatologists or plastic surgeons, others that are in the provider field. Skin inflammation can come from a number of things. We could have a long-term chronic skin disease that causes inflammation, and sometimes that would be a darker brown in that area where, say, a patient scratches because it itches. Other skin injuries, like sliding into third base and taking off some of the top cells of the skin, can result in a hyperpigmented area there. Melasma is a cause of hyperpigmentation that's more related to our internal biology, our hormone production. And there are certain medications, especially cardiac, heart rhythm control, blood pressure medicines. A few of those make us more sensitive to sunlight, so that sensitivity results in a pigment problem. And certainly there are medical conditions that can do that. But overall, it's an unwanted extra amount of pigment.
Is there any reason that some pigmentation brown spots are, sometimes we can take them off by doing chemical peels, but then they resurface? Is there any certain reason that some of them are just deeper than others or on the surface more? Is there something that causes that?
Well, there is, and I mentioned a while ago, most melanocytes are in the epidermal layer. In other words, if you had a blister, the fluid in the blister raises the epidermis away from the dermis. Some melanocytes can be attached or even get displaced down into the dermis, so you have a compound origin. And simply putting something topical may not eradicate or diminish those deeper dermal pigment cells without a chemical peel or something that actually takes that off. But you need to suppress the melanin entire surface area of the spot or of the pigment occurrence to get a good result, whether it's compound or just a superficial melanin.
Okay. There's some different types, and we were talking about there's age spots, which are also called liver spots. Those are the large brown, tan, or black spots that appear on the skin with sun exposure. You mostly see them on your face, hands, sun-exposed areas, skin areas. They usually appear on older adults or after extended sun exposure.
I would say also that age spots are different than those spots that are like birthmark brown spots, which we call cafe au lait, like the coffee color with cream in your coffee lightens it. So those that are there from birth are not going to be in the age spot or, the category we're talking about.
Okay. And mostly those are You see a lot of elderly people that have them on their arms and their hands. So those are what we're really referring to as their age spots, right?
That's true.
Okay.
Those are the ones that occurred due to some lifetime activity or exposure. Correct. Melasma is a term used for those pigment darker areas, almost always symmetrical, that occur in relation to some form of hormone activity. Let's back up a little bit, slide backwards if we can.
Okay. Oh yeah, I was in a different place, sorry.
Okay. I'm back on. It's everybody.
Yeah, we're right here. I was talking about melasma. Most patients or most lay persons, if you mention melasma, they would, and describe what it was, they would describe that as maybe what some people call the mask of pregnancy. During pregnancy, certain hormones increase, and those patients sometimes respond to that increase in hormone activity by making more pigment in symmetrical areas of the face. And usually it's a butterfly type distribution on the cheeks and forehead. And it's very difficult to cover with makeup. In other words, you put makeup on, you still see darker coloration in those areas of the melasma. So it's not harmful. It doesn't change into cancers or any systemic disease, but it's very unwanted by anyone that has those. Now, obviously, most men don't have ovaries, so we don't have monthly cycles that can cause that increase in pigment related to change in hormones. So it's usually associated during pregnancy with birth control pill use or with hormone replacement in a menopausal age woman. Then the post-inflammatory hyperpigmentation, also known as PIP, post-inflammatory pigmentation, leaving the hyper off. Those are areas that have responded after an injury or an inflammation, and it could be from a treatment to improve skin. Certain chemical peels, certain procedures that we oftentimes do in the office, like true dermabrasion, not microdermabrasion, but true, using like a sandpaper device or crystals on a wheel to take off that full layer of epidermal cells, can result in a post-treatment pigmentation. And so it's necessary for sure in those instances, including chemical peels, that we suppress melanin production in general. And when we do that, we get an even melanin production after that injury, whether it was caused on purpose or by accident. So we prevent rather than having to treat that hyperpigmented area.
All right. Darla, are you ready to go through the treatment options?
It is not showing on my screen.
Oh.
Okay, got it now. Okay, sorry, my computer went out a minute ago. I don't know what happened. Okay, treatment options. The TheraDerm products that we recommend are the New Pill Natural Enzyme Pill, the Fruit Acid Exfoliant, and the Enlighten Skin Brightener. I'm not sure if you're aware of the New Pill. It is a gel that you put on the skin. You put a light layer on dry skin and you leave it for about 45 seconds. And you let it set, and then you just start rubbing in a circular motion and you start getting the dead skin cells off, which helps exfoliate the skin. The Fruit Acid is also a 10% lactic product, which helps also exfoliate. You just do not see it. The Enlighten Skin Brightener is what we use that is kojic acid and L-arbutin to help with, even in the skin tone, helping with the pigmentation. It's best for patients with mild hyperpigmentation and a level 5 to 6 Fitzpatrick Scale skin type and melasma.
I would mention, going back up to products there, those first two are exfoliation agents. So when we're treating a pigment problem, we know by looking at it that there's too much pigment either all over the place or in selected areas. So we have to remove that pigment that's there. That's the exfoliation product or process. And at the same time, we want to prevent that increased production afterwards so that we get an even replacement. And that's what the skin brightener does. It actually suppresses the production of new melanin after we've removed that was already present. And as you mentioned, level 5 through 5 and 6 Fitzpatrick is the darker skin types. So a very dark Hispanic or black skin type, you want to go carefully when you're treating those pigment irregularities and not cause a darker result than you'd like to have because of injury. So darker skin responds to injury more readily and more severely from a pigment standpoint. So tread lightly when you're dealing with dark skin.
Would they, you know, you always tell us to test it on the forearm. Would that be something that they would need to do with the Fitzpatrick skin type? Would that help?
It never hurts, and it gives you more information, but it still may not answer the question. In other words, what post-treatment care is done, what other products they may use in their daily beauty routine, things of that sort. Certainly need to have that discussion before you're doing the treatment for those problems. But yes, those skin types, you need to have a discussion to understand those things, and so they understand them as well.
Okay. So some effective facial treatments that we do for hyperpigmentation is the lactic acid peel. They also do the IPL, laser resurfacing, the Jesner's chemical peel, the TCA peel, which is a more aggressive peel, and the microdermabrasion.
You know, you mentioned those different treatments on the top. A number of those are actual chemicals, and the lactic acid peel, when it's used as a peeling agent here, is because it's an alpha hydroxy acid. That refers to the chemical structure. In other words, the acid portion or the hydroxy portion in that alpha hydroxy acid is on the second carbon atom in a chain. And there are various alpha hydroxy acids. Glycolic acid only has 2 carbons. Lactic acid has 3 carbons, butyric 4, and so on and so forth. So when it was noted that alpha hydroxy acids tended to loosen the glue that holds skin surface cells in place, everybody jumped to have their own alpha hydroxy acid. Erroneously, glycolic acid is not metabolized by the body, and it can cause severe kidney problems because it's excreted as crystals in the kidney. Lactic acid, when used as a peel, and all of these have to be neutralized, but when lactic acid is used as a peel, it's neutralized, and the other ace in the cards that lactic acid has, it's the primary mediator in our immune system. So it has a lot of other roles that kind of supersede or override just the chemical acid component of it. It's actually beneficial to skin, and we'll talk more about that in a later thing. But IPL is energy from light waves, intense pulsed light. And of course, laser is a form of light waves, and laser resurfacing is removing, actually taking cells off of the surface. Whereas the Gesners and the TCA are actual chemicals that also loosen and remove those cells. Microdermabrasion is a physical removal. In other words, little grains of, think of particles of sand hitting the paint on a building, are taking some of the pigment out from that paint. It's also taking some of the cells off the surface that are ready to exfoliate but hadn't quite turned loose yet. So all those are effective facial treatments, but it's like if you raised hunting dogs, greyhounds are a lot different than poodles. So you have to train them different, you feed them different exercise, and their work is of a different nature. And that's the same with each of these modalities. They're all different.
So with any of these facial treatments, it's still, we had talked about this in first part of our Zooms, that the preparing the skin at least 2 weeks, which, you know, we on our prepare kits that has the enlighten, which helps with the hyperpigmentation. So that would be very important to be on those products 2 weeks before doing any of these treatments, correct?
Absolutely. You know, treatments, and we've talked about this in an earlier presentation, treatments are actually injuries that we cause to skin so that the healing eliminates a problem that had been there before. So yeah, pre-treatment needs to be there to increase blood flow and the general health of skin, but it also needs to include melanin suppression to prevent the post-inflammatory or post-treatment hyperpigmentation.
Okay. These are best for post-procedure hyperpigmentation, dark spots in areas, resistant melasma, and these are also great for level 1 to 3 Fitzpatrick and 4 to 6. So basically, it really helps when people have the hyperpigmentation. It's really a good starting part to kind of, do you think starting lighter of doing maybe the Gesner pills, or do some of them just go in because of laser and start resurfacing because they do have some more damage?
Well,
certain,
you know, there's not one size fits all when we're talking about both the treatments and the degree of severity of the but for treating a post-procedure hyperpigmentation, let's say the patient had a consultation pre-procedure, the skincare provider person explained they need to take these products before the procedure, but like happens not infrequently after you see the doctor, you don't remember all the things that went on in that conversation. You may forget and leave those products in the taxi cab on the way home, so you didn't have them when you got there, and you think, well, I don't want to be embarrassed and call the office and tell them I didn't have it. I'll just try to slip by without them. So there are reasons that you get post-procedure hyperpigmentation, and usually that's more a long-standing thing when a patient or client comes into the office for treatment that we're talking about here. But I would always start those patients for at least 2 weeks on a melanin suppression, and that's our enlighten product that contains 2 different powerful suppressing agents, for at least 2 weeks before we do any of those treatments above for the pigment removal.
okay. So we're kind of wondering if, you know, some people aren't real familiar with the Fitzpatrick scale. And so we kind of wanted to put that up there just to show there is different levels, you know, of their appearance, how skin reacts to different Fitzpatrick types. So, you know, we're not going to go over each one, but, you know, it is really important to identify when your patient comes into your office, which skin type they are, and to look, and I think it helps to identify how you're going to treat your patient also.
Well, this scale is based on the ability of a person's skin to resist problem pigmentation after a burn or after an energy, either a sunburn or, as it says, exposure to laser or or light-based treatments. And the skin types 1 through 6 were described by Dr. Fitzpatrick over 100 years ago. And that's a different Fitzpatrick than the Dr. Fitzpatrick that developed the TNS system that one of the skincare product companies has for growth factor type things. But anyway, this scale is a useful scale to predict how skin is going to react if you go out in the sun. In other words, what degree of sun protection might you need to have to keep from getting a burn. It also gives an idea of how gentle you need to be on skin to prevent causing a hyperpigmentation after a procedure. And those types 3 through 6 we talked about earlier, you really need to suppress that melanin production down before you do a planned injury to improve their skin. Now, type 1 is really rare. That's almost the albino type skin. In other words, everybody's got to fit in one of these, and the very lightest lack of pigment is what you'd see. The person that's in this with the red hair or blonde hair and freckles, those are usually going to be a low type 2 or a type 1 type patient. Now, albino obviously is a 1. The very darkest skin type would be the 7 or the 6. And so as those types increase in number, the amount of pigment in their skin increases also. So it's useful from one standpoint, but it doesn't tell you a lot of things about the sun damage that's already present due to their lifetime exposure, etc. In other words, the depth, the wrinkles, so on and so forth. Useful.
Okay. But does it also, when they are looking at it, it kind of helps them to determine that, like with the 6, that they need to be careful with how they kind of treat it with hyperpigment, with the enlighten because of the darker skin.
Yeah, as well as sun protection during that treatment itself.
Right. Okay.
Type 3 is the most common type. Most Americans, Caucasian Americans, are a type 2 or 3 in that group.
So it looks like we've got some pictures. This is like a treatment, a series of 8 Gesner peels with 1 week apart. It's looks like using 20 to 30% TCA peel could be done if the client didn't want. Okay. So it's a series of Gesners. There's no TCA. The client didn't really want any downtime. So it looks like she had a lot of kind of, well, it looks to me like freckles, but on
it kind of jumps out. If you think melasma and you look on her cheeks, the brown is very narrow over toward the nose, and it widens out as her cheek goes out toward the ear to even below the mouth, kind of a bat wing sort of distribution on both sides, and then the forehead. That's pretty classic for melasma.
Okay.
It is abnormal pigment that's there, and you're very correct in that doing a number of Gesner peels, a small tap hammer over a long period of time will remove a big dent, and a heavy hammer used on this lady would give some downtimes where she might have missed 3 or 4 days of work, several more days than are left on her allowed time to be off. But she can come in weekly and get a peel, and over a period of time go from first picture there to the very nice results shown in the second picture with pretty even pigmentation on her skin at the end there.
Right. And they can do a weekly Jesners as long as they are completely quit peeling, right?
Well, that's true. And I'll add that with Jesners, you know, it's a layered peel that self-limits, or you don't have to neutralize. And these wouldn't be 3 layers of Jesners every week, but maybe
Okay.
1 layer of Jesners and then weekly. So you might start on the front end in the discussion consultation with her. I think we can do 1 a week, but if we get to a place where you're still peeling or still irritated at the end of a week, we're going to wait and go 2 weeks. So we don't want to create more pigment. Be gentle.
Can you go ahead, like you said, you would start with 1 layer, and like maybe week 3 or 4, would you kind of move up, or would you kind of just keep the same pace and just gradually take care of this?
Depends on if she wants to be off work a day or 2.
Okay. Okay.
Do more layers, you're going to have
More peeling. Okay.
in peeling.
Okay. Just checking there.
That's a good question.
Okay, so on the Enlighten Skin Brightener, the unique benefits that it has, it's non-irritating to the skin. Its 2 main ingredients are the kojic acid and L-arbutin, which are naturally sourced. No need to cycle on and off. They're approved for use in the UK and the EU. It's included in our Prepare and our Prolong systems that you use 2 weeks before a procedure and then 2 weeks after. Preventive measure with any anti-aging procedures. So Dr. B, why is this so much better than when people want to use the hydroquinone?
Well, hydroquinone is a chemical that was used in the southern part of India primarily, where they had rubber tree plantations, and they'd harvest the sap from rubber trees in big 500-gallon vessels, and they'd add hydroquinone to it to cause that rubber tree sap to turn into a latex material. Now, latex is basically uncured rubber, and then they'd take the uncured latex and send it to tire factories or places that were making molded rubber goods. And they noticed that all of the folks that had stir these 500-gallon vats of this sap with a 10% hydroquinone in it, all of them were darker complected, because this is South India, where, you know, toward the equator, all peoples have darker skin. I mean, just genetically, it's evolved into a darker skin. They noticed all the men working in this industry, that by the time they'd been doing this for 2 months, the skin on their arms from elbows down had turned white. And when hydroquinone was being studied for use in the U.S., an article had come out that had studied the use of hydroquinone for pigment control in melasma and in the hyperpigment problems that we're talking about today. And so a study was done, a clinical study was done using prisoners that gave permission to be a subject in this study, putting a 1 square foot application weekly on their back over a shoulder blade. And these were darker pigmented, either Hispanic or black prison inmates that agreed to do this. And over a period of time, that skin actually turned light. They used one group of patients or one group of prisoners. They applied 2% hydroquinone, another group 4%, another 6%, another 8%, and another 10%. And the 2% hydroquinone had essentially no effect. It didn't really change the pigment coloration at all inside that square box. And these were 12-week, 3-month long studies. The 4% actually caused lightening, but it also caused some lightening by 12 weeks outside the boundaries of that marked off 1 square foot. And everything above that turned white even farther outside those lines. So the FDA, when this experimenter wanted to create a product that you could sell for a pharmaceutical company, the FDA said, well, no, we're going to limit using hydroquinone in less than 3% as an over-the-counter medication. You have to get a prescription for 4% or anything greater than 3%. And that's why hydroquinone that is really effective in a 4% has to have a prescription. Obviously, you need to see a physician to get that prescription. Then you have to go to the drugstore and get that prescription filled, and you're going to spend $50, $60, something like that, for enough of that 4% hydroquinone to cover your treatment time. So you've already invested $60, say, in something before you even get the treatment at the doctor's office. And the alternatives, kojic acid comes from a tree, and arbutin is also a vegetable source. And using those together, neither one of those caused that over lightening effect that you'd see with a hydroquinone 4%, but you get the melanin blockage or suppressant equal to a 4% hydroquinone. And obviously, you don't need a prescription to get it. You need to have our phone number, and we can send you some, but you don't need a prescription. It's an OTC if you want to look at it that way. And with the effectiveness of a 4% hydroquinone with none of the downside or the negative effects, the lasting widening circle of whitening, that sort of thing that they saw with the hydroquinone, doesn't occur. So you could use it every day for the rest of your life without a problem. Probably there hadn't been any, year-long tests with it. But if you're using a hydroquinone product, after 3 months, you got to quit using it for 3 months before you can get your prescription refilled again. I mean, that's written into what the pharmacist has to go by. And so if you don't have to cycle on and off, it's a very useful sort of thing. And you don't have to get a prescription filled. It's a cost-effective sort of thing. It's also approved for use in the U.S. and Canada. I didn't put that on this slide, but sometimes the EU is a lot more difficult to deal with their FDA equivalent, getting authorization to sell a product over there. California is almost as bad as the EU in terms of their strictness, but there's no problem using our Theraderm Enlighten in California, any of our states. Most people don't think about it, but hands are in that area that gets sun exposure, and certainly those folks that are in their 50s or 60s that might have grown up on a farm working outside in the fields every day, they get a hyperpigmentation of hands as seen in this upper 2 pictures. These are actually Polaroid pictures. The one on the to my right, as I'm looking at it, is the pre-treated hyperpigmented hand. One on my left is after treatment, and this is a more accurate picture taken with a real camera rather than what are those throwaway picture cameras we used to get. Anyway, this is regular film on the bottom done with correct lighting and things of that sort. But that's a result that you can see by suppressing the melanin with enlighten and doing a 20% TCA peel. This is a 12-week after picture. So that's a remarkable change that you can get. Not saying that at week 1 that was completely well. I mean, it's a pretty angry sort of peeling and all that stuff going on. So you got to be able to have, no pain, no gain is a real part of this. But that's the result you get.
Would they stay with Enlighten and sunscreen to keep those results?
No, I'd use it for a full 12 weeks after that, during that treatment.
During that time
period, post-treatment time period. Yeah, but be a little more active using your sunscreen.
Okay. Okay, we're talking about why broad spectrum protection sunscreen is a must when treating hyperpigmentation.
Well, all of us understand, just from when we're little kids, we want to grow up and have a nice pretty tan, so we go get out in the sun, because we know people that are in the sun get a tan. People that aren't in the sun don't tan as well. What we don't know is that, at that age, what we don't know is that we're damaging our skin by getting in the sun and getting an overdose. Even if we're not getting a true red blistering sunburn, sun damage is incremental, daily, cumulative over a lifetime. So when you have an injury, you definitely have a ripe and ready situation for getting hyperpigmentation if you overexpose that injured skin to sunlight. So that's one thing. When you're treating hyperpigmentation, depending on what you're doing, whether it's chemical or laser or other removal of surface pigment, you still want to suppress that lower level production of melanin. And that's why we use a sunscreen for that. Because even the smallest exposure to UV rays can stimulate injured skin to make more pigment. And if you have a hyperpigment area exposed to UV light, even increase melanin production at the cellular level while you're removing the upper level. So it's like sticking your finger in boiling water and then stick it in cool water and back into boiling water. It's useless. You're going to, no pain, no gain is true.
Right.
Now, in sunscreens, you don't need to use a SPF 220 if there was one. Most people say if you use over an SPF 15, and when I say most people, most researchers that study this say if you have a good sunscreen over SPF 15, you can control some of the incremental daily damage exposure. We think if you have a sunscreen in the 30 to 40 range that's non-irritating to your eyes, that's a UVA and UVB protection from the full spectrum of sun, that it's better. It's kind of like a patient or a guy with loose baggy pants can wear a belt and help a little bit, but putting a pair of suspenders on too sometimes can help. So we like our sunscreen. It's developed specifically to our formulation to give maximum protection and coverage with the minimum irritation, and fits with any skin type.
And also, just to kind of a warning to everyone, I know that a lot of times women want to leave after a procedure and they put their makeup on and they mention that, oh, it has the sunscreen in it. It might have, but after procedures and dealing with hyperpigmentation, you really need to have a good sunscreen on to keep from getting further damage. So, it's great to have the sunscreen in your, your makeup, but you really need to wear a sunscreen, I think.
Well, you think right.
All right, so we kind of, so basically we're wrapping this up, and we want to apologize. I had a few glitches just a minute ago with my computer, but they carried on. I do have one question for you, Dr. B, before we get off here. I have a lady that said that she got she has very all over darker skin tone last year after a laser training. It was very invasive, a 2940 laser. How can she bring back her very light skin tone, or can she?
Well, the first place to start when I get asked a question like that is I want to see a picture of it or see the patient. That tells me an awful lot of information about what we're dealing with. So I would say to that patient, take a picture of the skin you're talking about and email it to us, and we'll be glad to answer you with an email or phone call or something that way. But generally speaking, if you've got darker skin, you need to minimize the production of melanin, because pigment gets produced by a melanin cell down in the bottom layer, as we talked about. And as the general metabolic division of cells in the epidermis occurs, the cell divides and bubbles one to the top, and by about 3 to 4 weeks at a younger age, that pigment gets exfoliated with cells. So we know that exfoliation is going to occur naturally, but it also is producing new pigment at the bottom while that process is going on. So suppressing new melanin production at the bottom, and then light chemical peels, tread lightly on the exfoliation side, but something that increases the exfoliation rate would be beneficial. But I still want to see a picture. Those are generalities that I mentioned and not specifics for that lady.
And which leads us into what we want to do next week. We've decided that it would be great if you guys would send in problems that you've had with patients or just questions. And like Dr. Beckman said, he likes to see pictures so we can kind of help answer that. So next week our Zoom is going to be over you sending us questions that we can help answer, or pictures that we can look at and help you with the patient and try to help find out some answers. Also, I would love for you guys to send me some ideas on what you would like to see on our Zooms, things that would be important to you in your business, or just different questions that you have that we could talk about. So that's what I've got for this week. Anybody else got anything?
Well, I want to emphasize, if we can get between 5 and 10 questions from folks, it can be about a particular patient or client of theirs that has a significant problem they're wringing their hands over, or just want to get some extra advice for. Those are the kind of folks that we'd like to hear from. Send us a question that will help you, give you additional information in your practice and make your educational aspect more complete. So yeah, we look forward to helping people.
Right. And if you're going to send me a picture and a question that you want on this Zoom, I really need it by no later than Monday at noon so we can get this set up. So you've got my email. Just get it to us, and that way we will get you on and help get your questions answered.
And if,
I think that's it.
When they send questions in, we don't have to give their name. If they'd like a little credit for it, we can say, well, this is Susie Smith from Calcord, wherever, or we can put, this is initials of a real patient problem. So here. So if you want your name mentioned and get a little credit for your place of business, we'll stick that in there as well.
All right. Well, thank you for joining us. And if you have any other questions afterwards, just email me and we will get them answered for you. So we'll see you next week.
Bye.
Bye.